Next, coming to infective endocarditis. So, infective endocarditis has been described as one of the serious infection in developing world countries usually, but since because of the proper antibiotic therapy being introduced, this has been reduced to number. But when these conditions, when observed at an initial stage and have been ignored to treatment, then this could result as this could further become a complication. So infective endocarditis is one of the serious infection which involves a valvular as well as a mural endocardium, and it is usually caused because of certain various species of organisms, microorganisms, and it is characterized by it manifests with typical infection as well as with friable vegetations which can be observed within the myocardia, and suppose these are being progressive, then these can be carried in by the circulation into various other organs. So based on the severity of the infection, it is being divided into subbacterial acute bacterial endocarditis as well as subacute bacterial endocarditis, which is also known as endocarditis lenta. So coming to the various features distinguishing between this acute and subacute bacterial endocarditis, it is based on the duration. Suppose if the patient is it is for a duration of less than 6 weeks, then it is known as acute. Suppose it is for a duration of more than 6 weeks, then it is known as subacute. Coming to next feature is microorganisms, most common organisms which are being involved in acute and subacute. Usually in acute it is the Staphylococcus aureus as well as the beta streptococci which are usually involved, whereas in subacute it is the Streptococcus viridans which is most highly virulent or organism which causes this subacute stage of bacterial endocarditis. Next, coming to the virulence of the organisms, usually we see that the organisms which cause acute are usually highly virulent when compared to that of the subacute, which are less virulent. Coming to the next stage is the previous conditions of the valve. So based on the previous conditions of the valve, also these microorganisms might get adapted to that such kind of an environment or atmosphere which might help in its growth. So it is important to know the previous condition of the valve. Usually in acute cases of bacterial endocarditis, we see that the patient is not previously normal and has no such history of any heart diseases or disorders. But whereas in subacute, we see usually mostly the patient has a proper history saying because of a damaged valves or other kinds of heart failures or any cardiomyopathies which might help in progression of the already present microorganisms to progress and cause this disease. Next, coming as lesion on the valves. Usually based on the lesions present, this condition can be given with proper adequate therapies. So in cases of acute, the lesions are usually invasive and destructive as well as they are suppurative, that is producing pus causing. Whereas in subacute, usually we see that they are not invasive but they can be suppurative, or otherwise they might also invade into further other structures. So the clinical features which differentiate acute from subacute bacterial endocarditis is, in case of acute bacterial endocarditis, we see that the patient usually shows systemic manifestations such as fever, weakness, fatigue, or any muscular weakness or any reduced physical activity. But whereas in subacute bacterial endocarditis, we see that the patient usually complains of that clinically the patient can be observed with splenomegaly as well as clubbing of the fingers as well as presence of petechia, that is which are the usually blood marks which are present on the skin because of their because of the draining of the blood into the tissues. So these are certain clinical features which can differentiate acute and subacute, and these are certain distinguishing features between acute and subacute bacterial endocarditis. Coming to the etiological agents, it could either be because of an infectious agent or otherwise certain predisposing conditions. So amongst the infective agents, it is most commonly 90% of the bacterial endocarditis is because of the streptococci as well as the staphylococci microorganisms. Amongst the acute bacterial endocarditis condition, it is the staphylococci most commonly involved. Then followed by this severity, it is by pneumococci, gonococci as well as enterococci. So these are certain microorganisms which cause acute bacterial endocarditis. Coming to the subacute bacterial endocarditis, the most commonly organism which causes is streptococci. And then followed by this, other than the infectious agents, that is certain predisposing agents, that is certain conditions which contribute for the microorganisms to further multiply and adapt to that of the body, individual's human system, and then they try to grow in size and result in friable vegetations and infection of the myocardium. So among them, these predisposing factors, they are, first one is conditions which usually initiate the transient bacteremia, septicemia as well as pyemia. So the conditions itself, that is a compromised host, he might itself result or a previously present conditions of such as bacterial infections or any septicidal infections might hamper that of this organisms, which causes bacterial endocarditis and result in progression of this condition. And other than that, any underlying heart disease such as any damaged vessels or valves, they might also provide a proper environment for the microorganisms to lie on it and further grow. So underlying heart disease could also be one of the predisposing factor for the bacterial endocarditis to affect. Other than that, it is because of the impaired host defenses. Suppose if a microorganism on its first attack is not being removed by the host immune system because of the production of the cell-mediated factors or humoral mediated factors, then this can also result in bacterial endocarditis. So coming to the pathogenesis of bacterial endocarditis, it is usually the causative bacteria or the microorganisms. Once it starts entering the bloodstream, then it can reach through the circulation, and through the circulation it might invade into the cardiac system, and there it might lie or implant on the cardiac valves and otherwise known as mural endocardium with the help of certain surface adhesion molecules. That is, these surface adhesion molecules, they mediate the adherence of the microorganisms with that on the myocardial structures. Because of this establishment of this adherence, because of this surface adhesion molecules, it might further create a condition where the microorganisms can proliferate and result in bacterial endocarditis. So for this pathogenesis or for this adherence to be established, there are certain bacteria predisposing conditions known as circulating bacteria. That is, the bacteria already present within its normal limits in the body can also cause these circulating bacteria can also increase their levels in the blood because of this surface adhesion molecules. Next coming is the conditions which produce hemodynamic stress, such as if there's any cardiac output overload either on either of the ventricles or any increased cardiac output, it might ultimately cause hemodynamic stress. Because of this hemodynamic stress, there will be formation of platelet fibrin thrombi, which can also act as a predisposing factors for the circulating bacteria. Next coming is a non-bacterial thrombotic endocarditis. Among this non-bacterial thrombotic endocarditis is because of a presence of previously damaged valves, which might result in this accumulation of the bacteria and result as a predisposing factor for the bacterial endocarditis to be established on the individual. So there is a pathogenesis and certain predisposing factors. Coming to the distinguishing features between the vegetations in the major forms of the endocarditis. Coming to the complications and sequelae of bacterial endocarditis, as already discussed within the distinguishing features of acute bacterial endocarditis and subacute bacterial endocarditis. That is, in acute bacterial endocarditis, we see systemic manifestations like fever, such as high-grade fever can be seen, chills, weakness and malaise of the patient. These are the complaints which are being given from the patients in acute bacterial endocarditis. Whereas in subacute bacterial endocarditis, we see that there is only slight fever, fatigue, loss of weight as well as flu-like symptoms can be observed. Other than that, if the conditions are not being controlled, then it can lead into certain complications of such as cardiac complications. It might result in formation of perforations, aneurysms or any ruptures of the valve, or otherwise it might also result in myocardial abscess formation or abscesses in valve rings. any cardiac failure. It could result into any kind of cardiac myopathies in case of cardiac complications. Whereas extrapulmonary extra cardiac complications, we see that if there's any emboli which has been formed, this emboli, when it is being released from the left side, then it enters into the systemic circulation, whereas when it is released from the right side of the heart, then it enters the pulmonary circulation. So these are the complications when it involves the extracardiac areas. So otherwise, it might also result in glomerulonephritis. Nephrotic glomerulonephritis is also one of the complications which can be seen, or otherwise sequelae. So this is what is bacterial endocarditis. Coming to the types of bacterial endocarditis, these include based on the microorganism and the species. Usually we find tuberculous endocarditis, which is because of the Mycobacterium tuberculosis. And this mycobacteria, it might result in formation of tubercles, and it also causes tuberculous thromboembolisms can also be seen in such cases of when an endocarditis is because of tubercle bacilli. Suppose in syphilitic endocarditis, we see because in syphilis conditions, we see because of the Treponema palladium species, this results in endocarditis. It most commonly involves the aortic valves. Whereas in fungal endocarditis is because of the fungi species or organisms such as Candidiasis, Aspergillosis, Histoplasma. These are certain microorganisms which cause fungal endocarditis, but amongst them it is most commonly because of the Candidiasis as well as the Aspergillosis. In these conditions, usually we see when the patient affected with candidiasis or aspergillosis is on a fungal therapy, that is being given drugs against these fungal species or this infection. And if that patient is on a long-term antibiotic therapy for this fungal infections, then this can result in valve. Further, these drugs can have an effect on the valves and they cause damage, and this damage can be hampered or provide a condition associated for that with the growth of the fungi, and this results in fungal endocarditis. Next, coming is viral endocarditis. In this viral endocarditis, we see that it is not being confirmed amongst the human beings, but rather it is in experimental conditions which have proved that viral organisms have a role in creating endocarditis. Next, coming is rickettsial endocarditis. Usually this condition is seen associated with rickettsia in conditions of Q fever. We see that patients are being associated with endocarditis, so it is known as rickettsial endocarditis. So there is a picture showing the mitral valve fibrin vegetations on the left side because of the infection with Haemophilus parainfluenza. Because of this, there is a vegetation which is being seen on the mitral valve. Because of this, there is also hypertrophy can be seen, which is also shown with a scale measurement of a gross specimen. So this is of endocarditis. This of the features of the bacterial endocarditis. Coming to atherosclerosis. Atherosclerosis is a specific form of arteriosclerosis which usually affects the intima of the large as well as the medium-sized arteries, and it is characterized with the formation of fibrofatty plaques, or otherwise known as atheromas. So it is majorly a disease or a condition which involves the arteries, which causes its which blocks these arteries by forming certain fibrofatty changes as well as plaques, which is also known as atheromas. So it is most commonly seen involving areas known as areas of aorta as well as the arterial system, which amongst the arterial system it involves the coronary as well as the cerebral arterial systems. In the heart, it usually results in Anjara Pectoris as well as because of this plaque formation or otherwise atheromas which create a block for the blood flow circulation. It might also result in myocardial infarctions, which are also known as heart attacks. In brain, when atherosclerosis is seen affecting the cerebral arterial systems, then it might result in transient cerebral ischemia, that is a temporary condition for the restricted blood flow, which is known as transient cerebral ischemia, or otherwise results in cerebral infarct or otherwise strokes. So this is what we see in atherosclerosis when it affects the heart or brain. Coming to the risk factors in atherosclerosis. The major risk factor, they have been classified into two risk factors. One is a major risk factor and then is a emerging risk factor. Among the major risk factors, it consists of modifiable risk factors, and these modifiable risk factors are they are so-called modifiable because certain conditions among these risk factors which come under modifiable risk factors, they are the dyslipidemia, hypertension and diabetes mellitus, as well as smokers. So these patients, they actually have they are more prone to develop atherosclerosis. So they are known as modifiable risk factors. Usually when compared to smokers, when compared to non-smokers, smokers have a more they have a two times more increased prone to develop to atherosclerosis. Similarly, diabetic patients, hypertensive patients, as well as patients with dyslipidemia, that is abnormal lipoprotein metabolism, all these conditions, they have a more they act to be a contributing factors for developing atherosclerosis. Coming to the constitutional factors, among the age, starting with age, which is one of the constitutional factor, we see that atherosclerotic plaque, they might be formed within a younger age group, say such as a child age group, but they can clinically manifest once they grow to a larger size. So they have a property in developing amongst the childhood as well as in the adult age group. And coming to the gender distribution, it is most commonly seen in men when compared to women, and amongst the men it is most commonly seen in age group above 45 years, whereas in women above age group of 55 years. So there is one of the constitutional factor, that is the age as well as the gender. So they are even seen as a genetic hereditary, such as in patients with obese patients who have a genetic hereditary amongst them, since dyslipidemia is one of the factors. So we can also see atherosclerosis in obese patients. And then coming is a race. Usually it is more commonly seen in the whites when compared to the blacks. So these are certain constitutional factors, that is the age, gender, hereditary factors, genetical, as well as races. So these constitute the constitutional risk factors. Coming to the emerging risk factors, as already told, emerging risk factors, it could be hypertension, diabetes, or amongst the diabetes, it is a type 2 diabetes mellitus patients are more prone for the atherosclerosis to develop, and obesity is also one of the condition. So any physical reduced inactive physical activities when they are inactive or otherwise in stressful condition or obese conditions, they all constitute the emerging risk factors for atherosclerosis to develop. Coming to the pathogenesis, it is usually of two main hypotheses has been introduced. One is the reaction to injury hypothesis, and then is a monoclonal hypothesis. In the monoclonal hypothesis, we see that these patients with atherosclerotic plaques, they have been identified that instead of their two isoenzymes to glucose 6-phosphate dehydrogenase, this atherosclerotic plaques in these patients, they have shown only presence of one isoenzyme instead of two. So because of this, they have identified that this initial smooth muscle, which is a cardiac smooth muscle, showing presence only for one isoenzyme, this might have caused the proliferation. And so since there's only one isoenzyme which is creating this proliferation of this initial smooth muscle proliferation in atherosclerotic plaque, so this could have been the probable reason for naming it as monoclonal hypothesis, that is monoclonal, since this smooth muscle is of monoclonal origin. Next coming is reaction to injury hypothesis. So based on certain factors which occur, that is the sequential changes which result in atherosclerotic plaque or atheroma, has proposed for this reaction to injury hypothesis. That is, we've seen that first usually it is initiated with an endothelial injury. So any endothelial injury which could be because of any hemodynamic stress or any abnormalities such as injury or any chemical injuries with any drugs or any inducing mutations from smoke, from smokers, that is from the tobacco or any other inducing agent which result in damage to the endothelium, might cause the further accumulation of the platelets. This damaged endothelial, that is approximated edges, will result in accumulation of the platelets. That is, platelets immediately drive to the area of injury. Once they get driven to the area of injury, these platelets, they get attached, or they adhere to the edges of the wound of the endothelium, and once they get attached, these platelets, they get activated. Once the platelets have been activated, they release certain growth factors known as platelet derived growth factors. Next, after the sequence of the platelet activation and the release, then comes the accumulation of the inflammatory cells. They could be the neutrophils or the macrophages. These inflammatory cells, or otherwise the host immune cells, which fight against the area of the injury, that is in debriding the area with the neutrophils and the macrophages. Then these also, they release certain factors known as cytokines and interleukins. So all of these factors together, that is the growth factors which have been derived from the platelets, as well as the factors like cytokines and interleukins, which have been released from the inflammatory cells, all of them, they contribute to the proliferation of the intimal smooth muscle cell. That is the cells which are present within the intima of the arteries. They proliferate. Once these proliferate, this proliferation is being brought by the platelet derived growth factors, as well as certain growth factors and certain other adhesion molecules derived from the inflammatory cells. Once there's proliferation of this smooth muscle cell, there will be activation of the blood monocytes. That is, these blood monocytes these blood monocytes have usually membrane permeability. That is, they do not allow the low density lipoprotein molecules to enter within them. But we see in atherosclerotic plaques, that is, these blood monocytes or the monocytes, they provide an environment for the low density lipoprotein molecules to enter within them, and together with the monocytes, they result in a formation of foam cells. And these foam cells, they have a certain function in monocytes, that is, they cause the monocyte activation, immobilization, as well as the release of certain factors from this monocytes. That is, they promote the activity of monocytes, such as scavenger activity in the general host immune system. So this foam cells, that is the low density lipoprotein cells, along with the monocytes together function. They oxidize this foam cells and result in formation of oxidized foam cells. So this oxidized foam cells, which consists of low density lipoprotein, this further causes the this further gets oxidized and causes the alteration of the lipids in the blood circulation. That is, it might cause the alteration of the amount of the low density lipoprotein, as well as very low density proteins, as well as high density lipoproteins. All of these have an effect. So the role of dyslipidemia in development of atheroscleromatous plaque is, we see in these atheroscleromatous plaque patients who develop atheromas, that there is increase in the low density lipoprotein as well as very low density lipoprotein molecules. Both of these are usually harmful to any individual, but whereas high density lipoprotein is usually protective in nature. That is, it removes the bad cholesterol and tries to promote the good cholesterol, which is required for the nutrition in our body. But in atheromas which have been developed in such patients, which have so we see that there is alteration in this lipoprotein metabolism, where we see, rather than the high, that is the protective HDL to be present, there is present of more of LDL and VLDL, that is very low density lipoprotein as well as low density lipoprotein. So this also serves for the formation of atheromas in the patient. So this is the role of dyslipidemia. Next coming is thrombosis. So when we see in any injury, that is any injury such as say about in an endothelial injury in conditions of atherosclerotic plaque formation, we see that the endothelial injury might as soon as there's any injury, there's formation, aggregation of platelets. This platelets as they form platelet plug. So this fibrin plaque or the fibrin plaque might result in further accumulation of the platelet and result in a thrombus formation, and this thrombus has a more prone to develop with calcification and result in a formation of atherosclerotic plaque. So this contributes to the pathogenesis how the atherosclerotic plaque forms by monoclonal hypothesis and by reaction to injury hypothesis. So this is a picture which shows that a lesion is being initiated when there is damage to the endothelium. That is because of this, the LDL, that is low density lipoproteins, they enter the erythema and then they get oxidized and result in the formation of oxidized low density lipoproteins. This oxidized low density lipoprotein has an effect on monocyte, that is it might cause endothelial activation, and also it helps in differentiation of this monocyte into a macrophage, and this macrophage it releases certain cytokines as well as growth factors, which in turn causes smooth muscle proliferation and also helps in adherence of the leukocyte to the endothelium. So this is what we see in this result in fatty streak formation. And then comes the fibrous plaque formation. In the fibrous plaque formation, we see that in the environment which has been created with the platelet, fibrin, that is attachment of the leukocyte to the endothelial and formation of a platelet plug within the fibrin meshwork, as well as the activated platelets, which we can see in fibrous plaque formation in the picture. All these together along with the foam cell formation, that is low density lipoprotein along with the monocyte, is known as a foam cell. And the proliferation of the smooth muscle cell, which results in migration of the smooth muscle cell, all of this together associated with the cell debris and the formation of new blood vessel known as neovascularization together contribute to formation of a fibrous plaque. This fibrous plaque further along with the cholesterol crystals and further accumulation of the calcification results in a formation of thrombus, and this results in thrombosis. So this is what happens in reaction to injury hypothesis. Coming to the morphological features of atherosclerosis, usually we see certain forerunners in the evolution of atherosclerotic lesions. Among them, it is the early lesions which appear as diffuse erythemal thickening. Further, they evolve into fatty streaks, then into gelatinous lesions. So these are forerunners in a developing atherosclerotic lesion. And they usually appear initially as fatty streaks or otherwise dots which occur in the erythema, and then they progress into gelatinous lesions which show quite growth in their growth from a streak or a dot to a swollen or enlarging lesion. Then it develops into an atheromatous plaque, then into a complicated plaque. Among the complications, such as when an atheroscleromatous plaque is not being treated or not being removed, then it can either calcify, it resulting in a metastatic calcification. That is in a calcification is in a living tissue is known as metastatic calcification, and this calcification, that is accumulation of calcium salts as well as certain minerals and nutrients which are present in our blood circulation, they get accumulate when these salts and minerals are being accumulated on an already formed atheroma, then this results in calcification. So this is known as calcification. Otherwise, an atheroma, already persisting atheroma, may either ulcerate because of any rupture or otherwise any injury to the atheroma might result in ulceration, or it might also result in thrombosis, that is when there's any aggregation of platelet or fibrin or any thrombotic material such as granulation tissue material also. This material along with atheroma might result in formation of a thrombus, and this is known as thrombosis, or otherwise this atheroma might itself rupture and result in hemorrhage. Otherwise, it might also result in aneurysm formation, that is an abnormal circulatory system formation. So these are certain complications of atheroma. Coming to the how an atheroma forms initially on endothelial rupture or any endothelial damage. Initially, as in the picture we can see on the left side, it is because of an initially it is known as a lesion formation, that is in the form of fibrofatty streak or dot, where we see it is normally the endothelium is normal. There is no such alterations in the endothelium, but rather since it is an injury occurring, there is rapid migration of the inflammatory cells to the site of injury, that is macrophage infiltration can be seen. And as a result, there is also formation of foam cells, which I've also already discussed. That is low density lipoprotein along with the monocytes, that is the inflammatory cells, which this lipoprotein, when it enters the monocyte, it is known as foam cell. Then there's foam cell aggregation, and then this progresses into a fatty streak stage, where we see that within this injury side of injury, along with the foam cells and macrophages, there's also accumulation of the intracellular lipid. So this is known as fatty streak stage. Then comes the intermediate lesion stage, where we see that there is more of intracellular lipid accumulation and small amount of extracellular lipid pools can also be seen. As we see from the initial stage to the intermediate stage, there is progression of the size, that is of the injury starts progressing in size from early initial stage to the intermediate stage. Then this size also progresses as in the consequent stages, known as next stage is atheroma stage, where there is more of intracellular lipid accumulation, where the core of this intracellular lipid accumulation is being occupied by extracellular lipid, by which there is more in the increase in the size of the lesion. Then it ultimately forms a Fibro Erythema. This Fibro Erythema, it is usually single, or otherwise it is presents with multiple lipid cores, that is, which is a fusion of extracellular as well as the intracellular lipid material, as well as with that of the low density lipoprotein molecules. Then this forms, along with this, there's also formation of fibrous material, that is the fibers they accumulate, as well as on this fibers there is accumulation of the calcifying agents such as calcium salts and certain minerals in the blood fluid. By this results in a formation of fibroerythema, which results in a large lesion. Then this large lesion, if it is not removed, it results in complicated lesion, which shows surface defects such as ulceration can be seen. Other than that, even petechia can be seen, that is it could result in hematoma formation, that is large hemorrhagic area can be seen associated with hemorrhage, and then thrombosis can be seen, that is they might get detached also sometimes and result in emboli formation. So these are the stages of atheroma formation, and then the progression of the lesion, that is in the size also can be seen in the picture. Then coming to the onset, usually it is seen most commonly, atheromas are seen in the first decade of formation, that is in the childhood, but they do not manifest clinically. Rather, the growth of this atheroma being progressed with the formation of lipid accumulation might make it progress in size of the lesion and make it clinically available in further ages, such as in fourth or third decade. Usually it might clinically this atheroma might manifest. So we see in the third decade that from the first decade to the third decade, there will be lipid accumulation of this lesion. Coming to the fourth decade, that is from 30 to 40 years of age, usually we see that there is increased smooth muscle, as well as smooth muscle proliferation increases, as well as collagen fiber also increases. Because of it, the lesion starts progressing in size, and then it might clinically manifest. Finally, it will result in thrombosis or hematoma formation. So these are the stages of atheroma formation and their clinical manifestations as the age progresses in a patient who has been affected with atheroma. Coming to the types based on the atheroma formation, that is types of atherosclerosis, they have been classified into 6 types, and they are: type 1, it is known as an initial lesion stage, and type 2, it is known as a fatty streak stage, and type 3, an intermediate stage, and type 4, it is known as atheromatous lesion stage. Type 5, it is known as fibrofatty lesion stage, and type 6, it is known as complicated lesion stage. Based on these stages, as already described, the morphological features and the histological features and the age group, they also vary. Coming to the clinical features, how atheroma appears, there's low luminal narrowing seen, that is the lumina, that is the artery. There will be narrowing of the artery, which will result in ischemia, that is reduced blood supply, and then there will be sudden luminal occlusion, that is this atheroma might result in this atheroma formation might result in infarction or otherwise necrosis, that is a block in the blood flow is known as infarction. Now, then there will be propagation of the plaque can be seen. That is a plaque formation which has been formed. It tries to propagate. It might progress, might be progressive. And there will be aneurysmal dilatation. That is a compensatory mechanism will be adapted for the blood circulation, which might also result in dilatation. That is enlargement of the connecting veins or arteries. And other than that, in the aorta, it might result in infarction of the aorta. In the heart, it will result in myocardial infarction, as well as cardiac failure can also be seen. In brain, it results in cerebral infarction. In small intestine, we see there's some bowel intestinal disorders along with small intestine infarction can also be seen. In lower extremities, we see claudication as well as gangrene formation can be seen. So these are certain clinical features in atherosclerosis. So there is a picture. This is a microscopic picture. The first picture being stained with Masson trichome stain, where we see the artery along with all the three layers, intima, media, as well as the inner layer, that is a intima, that is a lumen of the intima being showing that is as narrowing of the lumen. Then next coming is calcification, that is progression of an atheroma into a calcification, which is a kind of complication or sequelae of atheroma. The next is a gross specimen, which is being shown with certain hemorrhagic areas also being present. So this is what is about atherosclerosis. Next coming is ischemic heart disease, or otherwise known as coronary heart disease, artery disease. It is usually defined as acute or otherwise chronic form of cardiac disability which arises from imbalance between a myocardial supply as well as demand for oxygenated blood. So this is what is ischemic heart disease, also known as coronary artery disease. Coming to the etiopathogenesis, it is most commonly because of coronary atherosclerosis, as already described. Because of any atheroma formation, ischemic heart disease can be described, can occur. Then it is also because of the superadded changes in the coronary atherosclerosis, that is any infections occurring in an already formed atheroma, or otherwise any further complications of the atheroma, such as ulceration or hematoma formation or calcification, or otherwise it could also occur as an individual in a non-atherosclerotic areas, because of any loss in the improper or inadequate blood supply. Coming to the picture, how an ischemic heart disease or coronary heart disease, artery disease is being seen. We can see that left side picture shows a picture of an heart where it has been identified with a circle. This which shows a higher magnification of that artery, where we see that there's fatty deposits being shown in the picture, with the formation of atheromas within the intima of the artery. Coming to the types based on the etiological factors, they are the coronary atherosclerosis as well as superadded changes and non-atherosclerotic causes. Among the coronary atherosclerosis, it is based on the distribution. So coming to coronary atherosclerosis, usually it is being distribution. Its distribution can be seen most commonly in the coronary artery and its trunks. That's amongst the three arteries. And coming to the location, it is most commonly seen 1/3 of the cases of coronary atherosclerosis, they have been seen in one vessel. 1/3 of the cases in two vessels of the coronary artery, or otherwise the remaining cases have been seen in all the three vessels. So it is most commonly in the coronary artery, and it's one or more of the three coronary arterial trunks. Coming to fixed, it could also be fixed atherosclerotic plaques, that is plaques which have already been for a longer duration. And coming to the superadded changes, it could be because of an acute changes, say such as in tachycardia or otherwise in any intraplaque hemorrhages. These could precipitate the ischemic heart disease or the coronary artery disease, in causing the superadded changes of an already present atherosclerotic plaques. Then next coming is superadded changes. It could also be because of a coronary artery thrombosis, that is if any atheroma has been complicated in untreated atheroma has been complicated into a thrombus formation, then it could result in a coronary artery thrombosis, which could also act as a superadded changes in an already present atheroma. Then next coming is local platelet aggregation, or otherwise that is any platelets which have aggregation on a present atheroma. Can also result in act as a superadded changes for ischemic heart disease to develop from superadded changes with atheroscleroma. Then the next coming to the non-atherosclerotic plaque causes, they include the vasospasm or any arterial, any inflammation to the arteries because of any direct injury or any drug-induced injury or chemical injury, or otherwise it could also be because of the stenosis of the coronary ostia. That is, the coronary ostia shows stenosis because of an incomplete or inadequate blood being passed through it, or because of embolism. And thrombotic disease could also be one of the reason for non-atherosclerotic causes for ischemic heart disease to develop, or otherwise aneurysms and compressions of the arterial system or the ventricles can also be one of the reason. So these are certain etiological factors which could result in ischemic heart disease or coronary artery disease. Next coming to the effects of the myocardial ischemia, we see usually the effects, it could be either asymptomatic or otherwise it can result in angina pectoris or any heart failures or congestive heart failures or any right or left side of heart failures. So these are certain effects of myocardial ischemia. It can also result in acute coronary system, which is a triad of acute myocardial infarction can be seen in such conditions, along with aneurysm formation and coarctation of the aorta can also be seen. Coming to Anjara Pectoris, it is a clinical syndrome, that is, it manifests clinically, which is an effect of an ischemic heart disease, and it usually results from transient ischemic. It is a condition because of transient myocardial infarction, and it is characterized by paroxysmal pain in the substernal as well as pericardial region of the chest. Usually patient complains of pain in substernal space as well as amongst the chest region, and this is being aggravated by increased demand of the heart. That is, in such conditions there is increased demand of the heart, that is increased workload stressed out on the myocardium, and which is being relieved by the decreased work of the heart. So this is the characteristic feature seen in angina pectoris. Other than that, there are certain clinical patterns of angina pectoris. They have been classified into stable or otherwise known as typical angina, or Presmental's angina, or otherwise known as unstable or crescendo angina. So see, these are certain clinical patterns of angina pectoris. So coming to stable or a typical angina, it is usually we see in such kind of patients, in such kind of clinical pattern of angina pectoris, we see that the attacks of pain are usually they follow usually when a patient is physically stressed out, such as in physical exertion or otherwise emotional excitement. This type of attack occurs, and it is relieved by rest. When the patient rests, patient gets relieved from it. It most commonly occurs, as said, it is because of a stress. The pathogenesis includes the stenosing of the coronary atherosclerosis will result in perfusion of the myocardium. This will in turn result in overworkload of the myocardium. So this is the pathogenesis why of stable typical angina. And coming to the changes in ECG, we see that the ST segment of the ECG, it is usually depressed in such kind of angina, this type of clinical pattern. Coming to Presmental's or otherwise Presmental's variant of angina pectoris, we see that usually the pain in this condition, it occurs when the patient is at rest and it is unrelated to the physical activity. And coming to the pathogenesis, it could be probably because of a sudden vasospasm of the coronary artery, or otherwise because of the because of the vasoconstriction by the mast cells on angina. So in this conditions, the ECG changes, usually we see that there is elevation of the ST segment. Next coming as unstable or otherwise crescendo angina, we see that there is frequent onset of the pain for prolonged duration, and it occurs when the patient is at rest, and it is indicative that myocardial infarction, that is acute myocardial infarction, is impending. And the pathogenesis is usually seen in coronary stenosing coronary atherosclerosis, because of which there is accumulation of platelets, and accumulation of platelets or otherwise the plaque becomes complicated and results in such type of condition. In this condition, we see that the ECG, there is non-ST segment elevation of the ECG. So these are the types of clinical patterns of angina pectoris. Coming to the picture, we see usually the patient complaining of pain in the chest region because of the pressure, fullness and squeezing. There's pain in the center of the chest region of the patient. That is in case of physical activity also, patient might complain of pain, which is one of the pattern of the angina pectoris. Coming to acute myocardial infarction, it is usually one of the consequence of the ischemic heart disease or coronary arteries disease. And the etiopathogenesis, it includes that is in case of myocardial ischemia, it might result in this acute myocardial infarction because of in ischemia there's a reduced blood supply. Because of this reduced blood supply, the presence of atherosclerotic plaques, they might act as an infarct and result in myocardial ischemia. And it could also be because of presence of any aggregation of the platelet mass, or otherwise already present acute atherosclerotic plaques might rupture and result in acute myocardial infarction, which may act as emboli and block the blood circulation. And it could also be because of a non-atherosclerotic areas. As already told, it could be because of a vasospasm or any arteriitis or any such kind of conditions. And it could also be because of transmural versus subendocardial infarcts, which are the type of infarcts. So there's a picture showing the acute myocardial infarction, because of which there's a block which is being formed within the ventricle. So there's a picture showing the right coronary artery as well as the left coronary artery showing the myocardial infarction. Coming to the types of infarct, that is the subendocardial infarct and the transmural infarcts. And it is important to know what kind of infarcts they are. So we'll differentiate the differences between these infarcts. So transmural infarct, it is a full thickness and a solid infarct, which can be seen as in acute myocardial infarction. Whereas coming to the subendocardial infarct, it is usually in a third to half of an infarct, and it is usually patchy in appearance, which can be seen. And coming to the frequency, that it is most frequently occurring infarct when compared to that of the subendocardial infarct, that is it occurs in 95% of the acute myocardial infarctions, that is transmural infarct, whereas this subendocardial is less commonly seen. And coming to its distribution, we see it is very prone to specific areas and most commonly to the coronary supply in case of transmural, whereas in subendocardial we see it is circumferential. That is, it is not particular to the coronary artery, but it might occur in and around the artery. And coming to the pathogenesis, we see that it is more than 75% of this transmural infarcts, it is because of the coronary stenosis. And otherwise, subendocardial infarct, it is most commonly because of the hyperperfusion of the myocardium. That is, when there is incomplete blood supply or inadequate blood supply, then it results in hyperperfusion of the myocardium and results in subendocardial infarct. Next coming is the based on the coronary thrombosis, it is most commonly seen in case of transmural infarct, but it is very rare among the subendocardial infarct. The next coming is the epicarditis stage. Epicarditis can be seen as a most common feature among the transmural, whereas it is not seen in cases of subendocardial infarcts. So these are the differentiating features between the types of infarct occurring in acute myocardial infarction. Coming to the types of infarcts, based on the anatomic region of the left ventricle involved, it can be placed at the anterior part or the posterior part or the lateral part, septal part, or otherwise at the circumferential part. And it could also occur in combination, that is anterolateral, posterolateral, or otherwise anteroseptal, interseptal. Coming to the degree of thickness of ventricular wall involved, they have been classified into two types, that is full thickness or otherwise known as transmural, subendocardial or otherwise known as laminar. Coming to the age of infarcts, they have been classified into two types, that is acute, fresh or newly formed infarct, or otherwise advanced, old or repaired infarct. Coming to the location of the infarcts, it is usually seen in the left ventricle, right ventricle, as well as at the atrial infarcts. And based on this, there have been three regions of the myocardial infarction to occur. Coming to the first one is stenosis of the left anterior coronary artery. It usually involves the anterior region of the left ventricle and of the anterior two-thirds of the interventricular septum. Coming to the stenosis of the right coronary artery, we see that is in the posterior part of the left ventricle as well as the posterior one-third of the interventricular septum. Next, coming as the stenosis of the left circumferential coronary artery, we see that is, it involves the arterial wall of the left ventricle. So these are the locations of the infarcts and the types of infarcts. Coming to the sequential pathological changes in myocardial infarction based on the duration, there are certain changes where we see in the first week, that is within first 6 hours, we see there is no such apparent changes which can be seen or observed, but under the light microscopy we see there is stretching and waviness of the fibers can be seen within the first 6 hours of the infarct formation. Coming to the next 6 to 12 hours, we see similarly as the first 6 hours, we do not see any such apparent changes. But under the microscope, we see that there is coagulative necrosis, which usually begins, and then this is followed by neutrophilic infiltration as well as edema and hemorrhage formation can be seen in the 6 to 12 hours. Coming to the next 24 hours of the infarct formation, we see the presence of cyanotic changes which are seen clinically, which appears red to purplish in color at the area of hemorrhage. And coming to the changes under a microscope, what we see is coagulative necrosis can be seen as in the previous 6 to 12 hours. Other than that, there is also marginal neutrophilic infiltration can also be seen. Coming as the time progresses, that is after the second day, that is second to third day, that is from 48 to 72 hours of the infarct formation, we see there's paleness as well as hyperemic, that is there's the changes in the thermal conditions can be seen. Then coming to the light microscopic changes, usually we see that there's coagulative necrosis which is completely occupied in the area of infarction. Other than that, there's also neutrophilic infiltration which is being well developed in such an area. Coming to the third to the 7th day, that is in the complete within a week, the changes from 3rd to 7th day, we see clinically that there's hyperemic border as well as center, there's presence of yellow and soft tissue which is present within the infarct. Whereas we see under the microscope, we see that the neutrophils, they have been completely necrosed, that is they are completely being, they are almost a dying type of necrosis which have finished their lifespan and completely they disappear because of the host immune system. And this is being replaced with necrosed fibers which is being produced by the macrophages, which are the second line of defense cells. Along with this, there is also certain fibrovascular response being initiated within the myocardium. So these are the changes which can be seen within the first week. Coming to the second week, that is by the 10th day after the infarct has been formed, the gross specimen shows red, purple changes, that is in the color at the periphery. Coming to the light microscope changes, usually we see there is presence of necrosed muscles which can be seen within a small infarct which has been removed. And coming to the 14th day, usually we see that there are no such gross changes which can be seen because this red and purple color could be progressive, and under a microscope we can see that there are necrosed muscle fibers which can be seen, which are almost removed, and their neutrophils have also been disappeared, and there is presence of fibroelastic changes or fibrocollagenic changes in the tissue which can be seen at the periphery of the area, in the peripheral region. And coming to the 3rd week, we see there's necrosed muscle fibers which are being seen in the larger infarcts which have been removed under a microscope. Coming to the 4th to 6th week, usually we find the gross changes is there's thin grayish white which is being seen, in fact, which is almost showing shrunken in appearance, and under a microscope we see that there's increased fibrocollagenic fibers, the tissue with decreased vascularity can be seen. All these changes, they can be accompanied with fibrous scar at the end of 4th to 6th week, as well as with pigmented macrophages can be seen under a light microscope with infiltration of the inflammatory cells known as lymphocytes and plasma cells. So these are the changes which we see, sequential changes in a myocardial infarction. Coming to the changes in the early infarcts, what we see is they could be based on the electron microscopic level or otherwise on the chemical as well as histochemical level. That is on the ultrastructural level and structural level. So the electrochemical, based on the electron microscopic changes, it has been observed that there is presence of perinuclear glycogen deposits. They start disappearing, and then other than that, we also see mitochondria start swelling, and there is disruption of the sarcolemma. That is the area which surrounds the which surrounds the vascular musculature of the cardiac muscle. That is, there's disruption of the sarcolemma can also be seen. Along with that, there are certain chemical as well as histochemical changes which we can see, that there's complete glycogen deposits. They are completely depleted, they are completely lost. Other than that, the biochemical changes, that is the chemical changes, we see that there's presence of lactic acid also increases in amount, as well as there's also increase in sodium in the ischemic tissue. And the potassium has started loss, there's loss of the potassium from the ischemic fibers can be seen. All these are the certain changes which can be seen at the electron microscopic level, at the chemical level, as well as at the histochemical level in an myocardial infarction. Coming to the diagnosis, it is usually based on the clinical features as well as the ECG changes, as well as certain presence of certain cardiac markers. So clinically, we find that the patient complains of pain as well as complaints of indigestion. Patient is always on shock because of the hypertension which is occurring because of myocardial ischemia resulting into an infarction, and oliguria, that is reduced urinary excretion can be seen. Other than that, patient might also complain of fever, and presence of pulmonary edema can also be seen. And ECG changes, we see that there is elevation in the ST segment as well as there's inversion in the T wave, and there's wide deep Q wave which can be observed in the changes of the ECG. Coming to the serum cardiac markers, usually we find that there's increase in the myoglobin level. Myoglobin is a kind of protein which is seen associated with the muscle of the cardiac muscle. Other than that, creatine kinase, which is being associated with the myocardium as well as with the muscle, skeletal muscle can be seen. Lactate dehydrogenase is also an enzyme which can be seen altered in these conditions of this patients. So these are certain diagnostic features which help in helping establishing a diagnosis of acute myocardial infarction. Coming to the pain zones, usually we see that the patient suffers pain in the starting from the chest zone, which might aggravate towards the neck and towards the arm region, and also which showing the backward part, which shows in the back region of the where pain can be associated. Coming to the complications, usually myocardial infarction, it usually results into arrhythmias. Arrhythmias are nothing but change in the rhythms of the heart, that is, it could be a diastolic or systolic rhythms. And other than that, patient might also end up into congestive heart failure and cardiogenic shock because of the hypotension in the systolic pressure which can be seen. Mural thrombosis and thromboembolism are also one kind of complication because of the infarcts which have been formed. So patient might result in mural embolism, mural thromboembolism. That is the emboli or the atheroma which has been formed at the primary site might migrate through the blood circulation. Once it has been dissociated from its primary site, then it's known as embolism, resulting in thromboembolism. That is, it forms in an organs from its other than its primary site. This is known as mural thromboembolism. In 5% of the cases, we can see that there's a rupture of the heart which might result in death of the patient, or it might also result in cardiac aneurysm. Mostly from the left side it is seen, that is shift to the left side can be seen. That is, pericarditis can also be seen in such conditions of myocardial infarction if not untreated, and then post myocardial infarction syndrome can also be occurring in acute myocardial infarction. So this is a picture which showing a heart attack. Why a patient occurs heart attack? Because of any block in an artery, it might cause result in obstruction in the blood flow. Finally, results in damage in the cardiac muscle, and result in heart attack. Coming to the chronic ischemic heart disease, usually it is also known as ischemic cardiomyopathy or otherwise known as myocardial fibrosis. It is usually characterized by focal or diffuse fibrosis, that is fibrous formation, where the fibers, myocardial fibers, fuse and result in a formation of diffuse or otherwise focal fibrosis within the myocardium muscle, and characteristically it is usually found in elderly patients who have progressive ischemic heart disease. And the etiopathogenesis, it usually involves because of the emboli which is formed in the coronary artery, or otherwise because of coronary arteritis, or the entire myocarditis might result in chronic ischemic heart disease. It could also be because of coronary atherosclerosis, that is the atheroma which have formed, which might progress and result into form into a chronic ischemic heart disease. And next, the other complicating factor is myocardial fibrosis, that is the entire myocardium which might progress into a undergo fibrotic changes because of the excess deposition of the fibers. They coalesce together, result in fibrosis, and under a microscope we can see that there is proper hyalinization of this cardiac muscle in case of myocardial fibrosis. Coming to the gross changes, what happens could be seen in this ischemic heart disease, that is in the chronic ischemic heart disease. The heart, because of the presence of fibrosis, it might occur as a hypertrophy, or it might be normally present. Coming to the left ventricular wall, it usually shows presence of fibrosis because of the fibers aggregation. Usually the heel scars, this myocardial chronic ischemic heart disease can also manifest as a part of myocardial infarct which have already been healed. That is, the heel scars of myocardial infarct might progress into chronic ischemic heart disease. Coming to the involvement, when it involves the left heart walls, usually we see that these walls, they are distorted, thicken, and further they may calcify as it progresses. If it involves the coronary arteries, we see that there is atheroscleroma formation, the atheroma formation can be seen. Coming to the microscopic changes, under a microscope, usually we find that is there is hyalinization of the myocardial fibrosis. It is known as myocardial fibrosis, and there is intervening, that is there is no proper alignment of this myocardial fibers, rather they intertwine around each other and give an appearance of intertwining of the myocardial fibers. There's also formation of brown atrophy can be seen, which is a very rare kind of manifestation which can be seen when special kind of stains have been used to stain this myocardial tissue. Other than that, there's even atherosclerotic plaques which can be observed, where we see that there's a narrowing of the lumen of the artery can be seen, most commonly which involves the coronary artery can be seen. Other than that, other features such as superimposed thrombosis can also be seen when observed under a microscope. Coming to sudden cardiac death, which is also one of the complications seen in heart failures. This sudden death, it usually occurs within 24 hours of time period from the cardiac symptoms such as pain in the substernal region and in the shoulder region can be seen. And the cause for this sudden death, it is most commonly because of an atheroma formation, that is in an atherosclerosis, or otherwise because of sudden vasospasm in the coronary artery can also be one of the reasons for sudden death to occur. Other than that, the non-ischemic causes, they include the calcification of the aortic stenosis, or otherwise it could also be because of myocarditis can be seen. The mechanism why this, that is a pathogenesis for this sudden cardiac death, is most commonly because of the fatal arrhythmias, that is abnormality in the systolic pressure and the diastolic pressure, that is cardiac rhythms. This fatal changes can result in sudden death. Other than that, it could also be because of ventricular asystole, or that is there is complete absence of the systolic pressure in the ventricles, or otherwise because of ventricular fibrillation can also result in sudden death. Morphologically, what we observe is there is presence of atherosclerotic coronary narrowing, that is a coronary artery narrows because of the presence of atheroma. Otherwise, we can also observe that there is superimposed thrombosis and plaque, which might result in manifest as hemorrhagic areas on an already present atheroma. So these are certain morphological features in sudden cardiac death.